All right, so the accreditation side. So just looking at learning objectives, kind of talking about the scope of the problem of substance use disorders in older adults, recognizing the importance for screening and some screening tools that you might be able to use in your practice, and then talking about evidence-based strategies for treatment and management of opioid and alcohol use disorders in older adults. Those will be some of the things we'll cover today. Next slide. So as we're all aware, and Nada, you can just click through and show all the text. Our population is aging rapidly. When I first gave a rendition of this talk in 2020, we were showing about 1 million older adults with substance use disorders in 2018. The more recent, like SAMHSA National Survey on Drug Use and Health showed 4.6 million older adults with substance use disorder in 2023. So this population is definitely increasing. For alcohol use, 65% of older adults reported exceeding the alcohol intake recommendations weekly, and about 10% reported binge drinking, 5+ drinks per sitting. So for someone 65 and older, that's quite a lot. This is older data, but I think just illustrates the increasing need. So between 2013 and 2015, one study showed that the population of people aged 55 and older grew by about 6%, but the percentage of that population seeking treatment for opioid use disorder grew by about 54%. So a lot of people coming out and seeking treatment. And just a reminder that while many older adults have aged with their substance use disorder, some will develop substance use disorders later in life. So I think the best studied example of this is alcohol use disorder. About 2/3 of older adults with alcohol use disorder are considered like early onset versus 1/3 being late onset, so developing it in their older years. Next slide. All right. So specifically about alcohol use in older adults compared to younger adults, older adults experience higher blood alcohol levels with equivalent dose of alcohol and increased risks of falls, hospitalization, and impairments, including cognitive impairment. And just to remind us, because I think in Wisconsin, many people exceed this. For people aged 65 and older, the NIAAA recommends no more than 7 drinks in 1 week, and no more than 3 drinks per occasion. And some individuals probably, such as this patient, need to drink less or not at all, depending on their health and how they're affected by alcohol. Next slide. So this can be an invisible population. Older adults are less likely to self-report a problem with alcohol use and sometimes less likely to ask for treatment than younger patients. And many provider beliefs and attitudes towards older adults can lead them not to screen for things like alcohol misuse or substance misuse. And Nada, if you want to click through a few more. One study I looked at showed, some of these attitudes being common among doctors. If they're this age and they're behaving this way, they're never going to change. They made it this far, it's not causing them issues. I don't have enough time in a visit. I don't want to be disrespectful given the person's age, asking about their substance use history, normalizing common things that might be a result of substance use disorder. So it's normal to forget things. It's normal to be confused. So we just really want to make sure that we are aware of those biases that we have when working with our older adult patients. Next slide. So SBIRT is something I'm sure people are familiar with. It's the model recommended that we use with any adult, I think, within our treatment settings in terms of universal screening and intervention. And then just to call attention, there is a SAMHSA Treatment Improvement Protocol 26 about treating substance use disorder in older adults. It's a really, really helpful document and it's free and accessible to use. So if you're treating older folks, consider taking a look at that. All right. And I'm sure this is preaching to the choir in this group, but it is recommended that we screen all adults age 60 and older for substance use and misuse annually as kind of part of a checkup and in behavioral healthcare settings. And we want to also check in, especially when major life changes occur. So if there's a major change in physical or mental health status, like falls or new memory issues, there's a major life event or change, like retirement is a particularly vulnerable time, moving, loss of a significant person in their life, all really good times to screen for substance use. All right, next slide. So some screening tools for alcohol use disorder in older adults. There is one study that recommends a different cutoff for the audit screener. So they recommend that for older adults, you consider it positive if the score is greater than equal to 5, and greater than equal to 4 for the audit C. This improves the sensitivity in older adults from 48% to 85%. In one study. The CAGE and CAGE aid questionnaires are very commonly used in settings. These have been shown to have variable sensitivity in older adults. Older adults are less likely to have someone at home to annoy them about their drinking, and it tends to be poor at identifying binge drinkers, which, as you saw in my first slide, is a big problem. Next slide. The screener I like to use with older adults if I'm suspecting alcohol use issue is this one. It's the Short Michigan Alcoholism Screening Test for Geriatrics. This is designed to identify drinking problems among older adults. It's got a sensitivity of 91 to 93% for alcohol use disorder. So if it's negative, you can probably rule out a full disorder with a little bit more confidence than some of the other screeners. And there was a study comparing this with the CAGE and found that this identified older adults who were drinking at harmful levels that had not been detected by the CAGE questionnaire. So this asks about some things, including like when you feel lonely, does it help having a drink? Do you drink to take your mind off your problems? Just some questions that might be more sensitive to our older adult population. Next slide. And then for other substances like CNS depressants, there's a severity of dependence scale. When studied in older adults, a cutoff of greater than 6 for detecting misuse had a sensitivity of 76%. So this can be a useful tool as well. Next slide. And then like for anyone after screening them, you would want to share results with the patient and get more information, complete a physical exam if needed, and refer for treatment if needed. All right, next slide. And I know I'm going through a lot pretty quickly. So this is just a reminder of the DSM-5 criteria for substance use disorder. And if you want to go to the next slide, Nada. For older adults, one paper proposed a little bit different application of some of these criteria for older adults that I find to be really helpful. So this table shows the DSM criterion and then, how the application might be different for an older adult. So for example, for like substance taken in greater amount than intended, our older adult population may be impaired more using the same amount that they took when they were younger. So you might need to consider that differently. Role impairment is definitely less pertinent in older adulthood. People might be retired or living alone. So that's something to consider very closely when assessing someone for substance use disorder in their older age. And then some of these things, we might get symptomatic impairment without an obvious need for increasing the amount. So again, kind of this presents in some cases a little bit different, and we might need to consider our criteria a little bit different. Just something about neuropsychological testing and substance use disorders. Um, a lot of times when we refer people for cognitive issues, for neuropsychological testing, we try to optimize cognitive risks such as substance use before testing. Um, Nonetheless, even if someone is using substances, this can be helpful in identifying impairment, and the pattern that we see on the neuropsychological testing can sometimes be helpful to pointing to like an etiology of impairment. So for example, people with alcohol-related dementias tend to perform better on semantic tasks and verbal memory recognition compared to Alzheimer's patients. Um, and then, yeah, we tend to get language sparing function. And sometimes this can even be helpful to demonstrate to the person that their substance use is having an effect on their cognition. And then we also just, a word about cognitive impairment. We want to remember that sometimes symptoms of cognitive decline and substance misuse can be similar. Um, and if someone is having cognitive decline, they're going to need a lot of support to follow treatment and recovery plans. Next slide. So, so when studied, these people should be treated. They're just as likely to benefit from treatment for their substance use disorder as younger adults. Um, Next slide, Nada. On these slides, you can read them more in detail. Canada does have guidelines on treating opioid use disorder among older adults. Um, it includes many of the same principles that we use for any patient. I'll call out some differences here. So if you go to the next slide, Nada, a lot of times we're taught that opioid withdrawal is not necessarily life-threatening. In older adults, we should potentially consider it life-threatening. Older adults who are more medically frail process the medications differently in their bodies and can be at much higher risk for adverse events or death, such as from electrolyte abnormalities, arrhythmias, and deconditioning. Um, Nonetheless, induction onto an opioid agonist is still recommended as the preferred treatment for people with opioid use disorder. And if you're not able to use an opioid agonist, you want to really monitor closely and treat symptomatically. So I would have a pretty low threshold to admit older adults for opioid withdrawal if needed. Next slide. And then buprenorphine is considered first line over methadone for pain control, tends to be less sedating, can have less fall risk because of that, less known to have respiratory depression. The metabolism remains stable into older adulthood, somewhat less cardiac risk than methadone, and it's more readily available for people who are homebound or in long-term care. So if people are on a methadone maintenance plan, try to think ahead about transitioning them to buprenorphine, maybe even in their 50s, just to reduce barriers to care in the future. Next slide. Many of the non-pharmacologic treatments for alcohol use disorder in older adults are the same as for younger adults. Next slide. For pharmacologic treatments, there's only 2 randomized control trials of naltrexone for alcohol use disorder in older adults. Both indicated that that was better than placebo. And in older adults, I preferentially use naltrexone, acamprosate, and topiramate over others just because of risk of side effects and medical comorbidities. And then my last slide just has some summary. So our substance use disorders are increasing among older adults. They benefit from treatment, but we have to screen them in order to figure it out. We should consider substance use withdrawal in older adults as potentially life-threatening. And when using any medication, go slow, use the lowest effective dose, and monitor closely for side effects.